Fortunately for patients and unfortunately for clinicians, I think in 5 years we're going to have even more agents and more therapies available to us. And we're going to have to select the sequence of agents, hopefully guided by well-designed clinical trials. I do think we're going to see a shift, and the THP regimen, which is now being used in early line neoadjuvant and adjuvant setting often, and the shift for the use of TDM1 in the adjuvant setting, we're going to see a lot of patients who develop metastatic breast cancer who've already seen those drugs. And so naturally, we're going to see third-line agents move up into the first-line setting. But given that 30 to 40% of our patients in the US at least develop de novo metastatic HER2 positive breast cancer, we'll still be using trastuzumab, pertuzumab, and TDM1. I think in 5 years, we're going to start to see phase 3 evidence that may challenge the current positions in the front line and second line setting. So we might see DS8201 in first line or second line. We might see tucatinib in one of these lines. And I'm most excited actually to explore whether or not tucatinib can mitigate or prevent the development of CNS metastases. So my hope, and it's quite a high hope because it requires two companies coming together, would be that we'd see a combination of something like DS8201 with tucatinib, taking the efficacy strengths of both molecule to help improve outcomes for patients.
In 5 years, we're likely to have new strategies to treat breast cancer broadly and HER2 positive disease specifically. I anticipate that the drugs that we talked about today will, at least many of them, be approved. And one of the things that inevitably happens as you develop drugs is the goal is always to move them up in the algorithm. So in other words, they're pretty traditionally developed in metastatic disease, and they start moving towards earlier in metastatic disease, and where everybody wants to get their drug is in the adjuvant setting for a variety of reasons. There are more patients, but most importantly is if they show significant efficacy in the metastatic disease setting, the question is, can you diminish the number of patients that will ultimately recur? So in other words, you're curing more patients. So all the drugs that we're talking about, if they're effective, if they're approved, there are likely going to be trials looking at them earlier and earlier. And two things will come of that. One is, hopefully, there'll be fewer patients with metastatic disease, which is a good thing. But in those patients who do develop recurrent disease, we'll have to have new strategies. And I think one of the things that we talked about earlier is looking at novel combinations of HER2-directed therapy with immune therapy as a way of, enhancing our own immune systems to treat cancer. So I think that we will likely continue to have new drugs developed, antibody drug conjugates, novel TKIs, probably even antibodies perhaps that are different. We talked about bispecific antibodies earlier. And whether these strategies pan out, we'll see. But I think that by virtue of moving the existing drugs up, we're going to have to fill that void with newer drugs, and that's really the subject of the clinical research that is just starting with some of these compounds.